Welcome, everyone, to our 5th RxTalks webinar, brought to you by Omeda Rx. We're happy to see some returning people and some new people in today's audience. Today, we have our resident speakers, our own Dr. Lam and Rich Adams, and a special guest speaker, Dr. Alex Dong. My name is Dana Madison, and I'll be one of your moderators, joined by Allison Donahue. We'll be keeping things running behind the scenes. Today, I'll go over some housekeeping items, introduce our speakers, then pass it over to them to review our topic, and we'll wrap up with a questions and answer session towards the end. Out of respect for our presenters, everyone is automatically muted. We will capture questions throughout the presentation using the dialog box. Simply submit your questions, and we will send them to the presenters to read and answer later in the presentation. Today's session will be recorded. As mentioned, our speakers today are Dr. Steve Lam, Dr. Alex Dong, and Rich Adams. Dr. Steve Lam currently serves as a clinical pharmacist client manager for Omeda Rx, where he has strategic responsibility for developing, communicating, and reporting the outcomes of clinical initiatives impacting both cost and quality of care to members and clients. Prior to joining Omeda Rx, Steve was a resident pharmacist at a large health plan in Oregon, where he was exposed to a variety of roles, including formulary management, prior authorization, government programs, and specialty pharmacy, as well as clinical operations and administration. Dr. Alex Dong currently serves as a clinical pharmacist consultant for Omeda Rx, where he supports pharmacy outreach and educational teams, focusing on quality programs and cost stewardship initiatives, and also he's also an outreach rotation preceptor for our managed care pharmacy residency program and our advanced pharmacy practice experience coordinator. One of his areas of expertise is site of care optimization. Prior to joining Omeda Rx, Dr. Dong worked at an independent pharmacy and the University of Arizona's Medication Management Center, in addition to serving as an English teacher in Madagascar with the Peace Corps. Rich Adams currently serves as the Director of Product and Business Development at Omeda Rx, where he oversees sales, account management, and product development. Before coming to Omeda Rx, Rich held various sales leadership positions at industry-leading healthcare companies. Rich's career work focuses on helping organizations navigate the new health economy. With that, I'm going to hand it off to Rich Adams. Rich, take it away.
Hey, Dana, thank you very much, and thank you, Allison. Dr. Lam, great to see you again. Thank you for joining us.
Thanks for having me again.
Dr. Dong, it's an honor to have you here.
Likewise.
As a program, yeah, absolutely. As a program manager for site of care, you have deep experience in this area, so we're excited to talk to you today about your expertise and learn more about medical drug management. So today we're talking about medical drugs, and they are some of the most pressing costs for employers and employees. They're different. They present unique challenges to us from a management perspective and an administration perspective as well. And to be successful in managing these, we need to have an engagement and a collaboration model that encompasses the entire delivery system. So our agenda today starts off with an overview of medical benefit drugs and medical benefit drug management. Second, we take a look at critical elements of an effective medical drug management program. We then highlight the value for patients, employers, and providers of an integrated site of care program. And then, as we normally do, we're going to have a few questions that we've put together that the audience can pose when they're evaluating a site of care program or a medical benefit management program. So here we go. So let's back up and remember our challenge. Our challenge, as we outlined in our very first, we're having a little bit of trouble here with our slide changing. Sorry about that, everybody. Our challenge, as we outlined it in our, our challenge, as we outlined it in our very first webinar, our 5x5, we presented a situation that showed that pharmacy costs were increasing by 6.9% per year through 2025. We outlined the top cost drivers. We talked about brand price increases, specialty drugs in the pipeline, medical benefit drugs, the FDA increasing their approval rates with their new accelerated program, and also pharma advertising. We also talked about, and we've been discussing, what can we do about it? We began with evidence-based medicine, early, accurate, and personal, understanding which medicines are good and which medicines are better. We then went to integrated drug utilization management, the ability to look at all drugs, whether they're on the pharmacy benefit or on the medical benefit. We then talked about personalized specialty drug management, the ability to wrap a program to wrap itself around a patient as they're experiencing a specialty medicine. We will end with, next time, talking about innovative consumer engagement programs, but today we're talking about medical benefit drug management or sites of care. So as we look at that, and as we begin, let's start off with and return to the drug pipeline. Dr. Lam, help us understand what are drugs that are on the medical benefit? How are they different? What conditions do they address? And how does administration vary?
Sure. Thank you, Rich. So on this diagram that you see here before you, these are our specialty drugs. There is a green line that separates the pharmacy benefit and the medical benefit. Drugs that lie on the pharmacy benefit are the ones that are above the line, and the ones that are below the line are our medical benefit drugs. And the question you had was, Rich, how do you differentiate between pharmacy and medical drugs? And there really isn't a science behind it, and there isn't really a gold standard definition at all. Really, if we look at this historically, how we have defined this is pharmacy drugs are typically those that you can take safely at home. These are typically drugs that are taken orally, transdermally, etc., or even sometimes injected, like your insulin. Medical benefit drugs are a little bit more complex. These are large molecule drugs that sometimes require intravenous or IV infusion, or they can also be injected. But these injectable drugs are not suitable to be done at home for safety reasons.
Let me ask you a follow-up question, Dr. Lam. As we look at the pipeline overall, from just the conception of a new medicine all the way through approval by the FDA, we know that it's a very big number. It's about 7,000 drugs. We also know that as we look at a snapshot of the current pipeline, it's phase 3, phase 2, and phase 3, about 53% of the medicines are on the medical benefit side of it. Do you see that continuing, or do you see that perhaps getting smaller over time, or even larger as a percentage distribution?
Absolutely. As we kind of look into 2017 and even into 2018, around 50% of the drug pipeline will continue to be medical drugs. Research today is really heavily focused on areas such as oncology, orphan disease states like Duchenne's muscular dystrophy, which really affect less than 200,000 people worldwide. And they are usually drugs that are IV infused and covered on the medical benefit. As we begin to look into the future, we may see more pharmaceutical advancements, technological advancements, and more of these drugs might be able to be used via orally or through other routes of administration. But whether that happens in the next year or even 2 years from now, we aren't quite sure. There really needs to be a lot more advancements in technology before we see that happening and before more drugs moving back towards that pharmacy benefit of the pipeline.
So we've got a challenge. The challenge is pretty big from a volume standpoint, and it's not going away. Let's talk a little bit more about the administration and management of medical benefit drugs. Dr. Lam, how do we go about managing them? Do they present unique challenges? Are they complex? Walk us through it a little bit.
That's a great question, Rich. And really, there are a lot of challenges with managing medical drugs. If you look at this slide here before you, the first one says more complex care and care delivery. What we really mean by that are these drugs are often IV drugs or IV infused drugs and injectable drugs that need to be mixed within a clean room, which is really just a sterile environment to ensure the product isn't adulterated when it's being mixed or manipulated. Medical drugs also have to be administered by a trained healthcare professional, so oftentimes a nurse, so that the patient can be monitored appropriately. Other challenges that we see are with claims and billing. So claims and billing is a significant challenge just because the cost of the drug and its administration really depends on the location or the site that you get it at. The way that the medication is billed has a significant impact on how we manage these medical drugs. And the last challenge that we typically see is that they're more complicated access to care. Patients access these drugs differently than those that are on the pharmacy benefit. On the pharmacy benefit, the patient can go to their local brick-and-mortar store or pharmacy and pick up the medication, or they can have the medication shipped directly to their doorstep. Medical drugs are not that way. Medical drugs require a patient to set up an appointment, drive to the site of infusion, find parking, wait, and then get the drug. This is a very cumbersome and time-consuming process. So all of these really add up to more challenges and more expensive care. But in our experience here, we actually haven't seen that more expensive care necessarily leads to a better patient health outcome.
That's good information, Dr. Lam. Dr. Dong, question for you. What conditions are we talking about here? Are there specific categories of diseases or healthcare conditions that medical benefit drugs address, or is it across the spectrum?
So that's a great question, Rich. They do cover the spectrum of disease states. Some examples include rheumatoid arthritis, psoriatic arthritis, Crohn's disease, ulcerative colitis, cancers, rare enzyme deficiencies. So those are just some of the disease states that medical benefit drugs address.
All right, hey, thank you for that. So we've got a lot of these drugs that are in the pipeline and have been released. It's not going to get any smaller. They're complicated. They're hard to access. It sounds like they address very complicated health conditions. Let's talk about it from a cost perspective. As we look at it from a cost or a pricing perspective, Dr. Lam, share with us a little bit about what the business models are that are out there. How does it break down into the delivery of care?
Yeah, the cost thing is a very unique and challenging aspect to manage, but really to understand what the differences in cost are and why there's a difference in cost, you really need to look at two different things. The first one is how the medication is billed, and the second one is associated with how the medication is administered and billed that way. So first, let's talk about how a medication is billed and the price around the drug. Pharmacy benefit drugs are billed using a national drug code, short for NDC, which normally includes drug information as pertaining to the drug strength, the dosage size, package size, as well as who the manufacturer is. So a drug that is billed at that NDC level really gives us more visibility over the cost of the drug, which provides accurate payment and management opportunities. Medical drugs, on the other hand, are not as straightforward. There's not a lot of visibility around the way the medication is coded and billed. They can be submitted via paper claims, which is a very archaic way of doing it. These medical drugs are coded differently than pharmacy drugs, so instead of using a NDC, they are coded with what is called a J code or a HCPC code, otherwise known as Healthcare Common Procedure Coding System. This style of coding doesn't give us a lot of visibility into the medication's manufacturer, strength, or package size like an NDC would. Additionally, there are numerous challenges with J codes being shared by drugs within the same class, and sometimes newly approved FDA drugs will be assigned an unclassified J code, which is not very helpful when you're trying to track a medication, how much it costs, and how much was administered. In these situations, we really do not have that visibility that we require. The billed J code also isn't standardized, which further complicates things. So one J code that you get at one facility for a drug might not cost the same as another J code that is billed at a different facility for that same exact drug. So really there's a huge, huge challenge in the way that how we manage these drugs based on the way that it's billed. So all of these things just make management very difficult. Therefore, the total cost of care can differ significantly depending on the site. So if you look at the graphic on the left here, the total cost between an outpatient hospital infusion versus a physician's office infusion can sometimes be double. If you look at the cost of the drugs, which is the diagram on the right, the average cost can sometimes be double, triple, or even 7 times greater. So let's take a look at Neulasta, which is the top one on there. This is a subcutaneous injection. It costs $70 more in the hospital setting for the same drug, same dose, and same quality of injection by a nurse. Now let's look at Rituxan, which is at the bottom of this diagram. This is an infused drug, so IV infused. It costs $700 more to be infused within a hospital setting. And this is just the administration of the drug cost. So total, the cost of the medication is going to be more, and also the administration cost of the drug is going to be more. This is quite worrisome for us.
So in addition to an increasing volume of medicines, complex care, complex administration, we're folding in here what sounds and feels like an opaque cost structure, an opaque pricing structure, which has two components to it. You've got the cost of the medicine itself, and then you have the cost of the administration, and those two elements can vary by where you go. Difficult situation, hard, much, much different than traditional pharmacy benefit management of drugs that are on the pharmacy benefit side. You mentioned, Dr. Lam, you mentioned that prices vary between sites of care, of delivery of medical benefit drugs. And over the last several years, we have seen hospitals and hospital systems acquiring physician practices at an unprecedented rate. How does medical drug benefit management fit into that equation, if at all? And is it a market force that we need to pay attention to and having a dramatic impact on this type of medicine?
This is absolutely a trend that we should keep our eyes on. We recently saw a lot more hospital systems and independent hospitals acquiring more infusion suites or even building their own infusion suites, trying to gain scale, particularly around oncology and rheumatology. This is a significant revenue stream for hospital systems, and underneath a traditional buy and bill model, hospitals are able to make a certain markup after they buy the medication, infuse the medications, and then bill the health insurance for the cost of infusing the drug. So this really reached a peak in 2015, but as we look into 2016, this trend might not be continuing just because of the increased prices of medications around oncology and rheumatology. But still, it's something that we definitely need to keep our eyes on.
All right, thank you, Dr. Lam. Question for you, Dr. Dong. On this slide, it mentions something called brown bagging, and I've heard about that. Could you share a little bit about what is brown bagging and white bagging as well, and how that fits into medical drug management?
Great call out, Rich. So with the brown bag concept, that's where instead of the regular process, the drug goes from the specialty pharmacy directly to the patient, and the patient is expected to take that drug to the provider to be administered. In contrast, the white bagging concept is where the specialty pharmacy gives the drug directly to the provider, and then they administer the medication to the patient. So those are really in contrast, and they are fragmented compared to a site of care program that's a more integrated and holistic model where the patients have their choice of sites where they can go and where they can get their medication infused, and it's a better experience for the patient and the provider.
Would it be, a follow-up question for you, would it be fair to say that the brown bag and white bag solution is primarily focused on cost and not necessarily focused on some of the other elements that we've talked about?
That is correct.
That's correct. So it's kind of looking at it from one dimension.
I would also like to add that really this white bagging and brown bagging approach is more of a band-aid approach that's taken by certain PBMs, just because it really does, you're right, Rich, it fixes more of the cost issue around that drug. But we still haven't looked at, the medical bill for the administration of the drug. So you still deal with this phenomenon, what is called split billing. And it's cumbersome and challenging to, really identify how to marry both of those and manage both of those appropriately when one's being billed on the medical side and the other is being billed on the pharmacy side. So although it is a viable strategy, it is very difficult to coordinate, have an integrated system, and really site of care has the ability to kind of marry those and really does a great job of taking care of those issues.
Thank you, Dr. Lam. So we've laid out a pretty significant problem statement here, right? We've got expensive drugs, complex to administer, fragmented in the delivery system, very hard to track, report on, the pricing is opaque. Let's talk about an ideal model. Dr. Dong, what does an ideal site of care or a medical drug management program look like?
So an ideal program includes the elements listed on the slide. So For example, comprehensive medication insights. Second, a robust utilization management strategy, a broad infusion network, improved patient experience, and progressive facility relationships. So I'll actually defer to Dr. Lam for additional details on that.
Yeah, so in that comprehensive medication insights piece, it's really a way for us to discern which medications are best to include within a program. And that robust or utilization management is the prior authorization piece so that we can ensure patients always get the best drug possible at the best value. The broad infusion network is more of the ability for the patient to choose from various sites that work best for them. And then in all of this, we really want to make sure that we have improved patient experiences, which takes away the operational and the administrative burden for them. And we really want to maximize that convenience factor for our patients. And then lastly, that last prong that we have there is the facility relationship, where payers and hospitals can sit at the same table and negotiate appropriate rates across the care continuum, not just for the administration of medical drugs, but how do we kind of get these patients to their hospitals as well.
So a confirming question for both of you. I would imagine that a brown bag or a white bag solution would actually just hit one or two of these buckets. For example, you could have a comprehensive medication insight program, but a very, very narrow infusion network, right? One delivery place from a specialty pharmacy. That would not be a holistic approach. That would be a brown bag or a white bag approach, less effective than the integrated approach that you all are advocating here. Second question, what is the difference between a broad infusion network and a progressive facility relationship? I would assume that the facility would have to be part of the network, so isn't that kind of double counting here when you look at the integrated model?
There is a nuance between those two concepts. So when we're talking about a broad infusion network, we're talking about all the options available to the patient, that they can get their drugs infused in a doctor's office, a standalone infusion suite with home infusion services, as well as a hospital outpatient setting. And when we talk about a progressive facility relationship, we're talking about the contractual obligation between the health plan and or PBM and the hospital or other site of care. So it's really that contractual relationship where some hospitals have renegotiated their rates to be more comparable to the site of care market, so that if a patient goes to those hospitals, they actually get reimbursement or they pay a similar rate to the other sites of care.
All right, outstanding. So we've outlined an integrated approach here. Let's dig into the comprehensive medication insights portion. Dr. Dong, you had talked about the conditions where site of care drugs are delivered, rheumatoid arthritis, multiple sclerosis perhaps, cancer, enzyme disorders. Dr. Lam, how do clinicians determine which medicines qualify for a site of care program? Which ones are included?
So when we look at the entire care continuum, all the drugs that are approved by FDA, on the very left, these are all the entire bucket of drugs that are there. And then what we do is our clinicians here, our clinical pharmacist does an evaluation of these drugs to look at a drug's safety, efficacy, the medical necessity of the drug, and then also the value. So we really have three core elements within that clinical evaluation bucket to make sure that those drugs that are approved by the FDA are safe and appropriate. After that, for a site of care program to work, we do an additional filtering step. And this filtering step is really to identify drugs that are appropriate for management within this type of program, because not all drugs are. And Dr. Dong can kind of talk about some of those drugs later on about why they would be suitable for a program such as site of care.
That's a good opportunity. Would you like to give us an example, Dr. Dong, of a drug that has been evaluated and put into the site of care program?
Yeah, so again, just going through, starting on the left part of the slide with the FDA-approved medical drugs, that includes an entire spectrum of drugs that have been vetted through the FDA process of efficacy and safety, and as Dr. Lam mentioned, there's a clinical evaluation component looking at that safety and efficacy, as well as including the medical necessity and the value of those medications versus alternatives, existing alternatives, and their cost. And so when we think about medications to include within the site of care program, we really think about the patient experience, the provider experience, as well as the clinical experience of these drugs being administered in other sites of care. So, for example, Remicade in the past decade has a lot of experience within the home infusion and alternate sites of care. So within those settings, we're confident that these drugs could be administered and are appropriate for a site of care program. In contrast, cancer, oncology drugs are not included in our particular site of care program, and that's because of a lot of the issues related to the relationship with all the parties involved, and it's very sensitive. And so based on a number of different factors, we at this time have not included those drugs within the site of care program. So those are two examples of drugs that we have included and have not included within the program.
As you, Dr. Dong, as you step back and you look at site of care or medical drug management strategically, do you see the number of medicines that are included in the site of care program now, do you see that expanding over time and ever increasing, or is it set in time and it will never change?
So we do expect it to expand over time, and part of that is site normalization. So as members, patients, and providers understand more on the cost differential between hospitals and other sites of care, and they get used to the conveniences and the benefits of alternate sites, we expect that to increase. Yes.
Thank you for that. Well, let's see how it plays out practically. So, Dr. Lam, walk us through how it is for a patient and a provider. What do they experience? What are they going to see and feel?
Sure, yeah, happy to do that. So like any medication, the patient will typically go to their provider, and the provider will write them a prescription. When you have a site of care program, there is a middle step, and this middle step has a lot of the operational and clinical engines that happen within the background. This engine really ensures that the right patient is getting the right drug at the right dose, at the best value, and then with site of care also at the right location. If it is identified that the patient meets medical necessity but requires to get the infusion at an unapproved site, typically the patient is reached out to and they're provided with some alternative sites that they can get their infusions at. So under such a model, the patient will still get that high quality care at a much less costly dollar. So once you manage medications with a site of care process, you really get the ability to manage where they go, as well as how much that is going to cost for them, and as well as for the plan.
Thank you, Dr. Lam. I look at this chart here and I see I've got a hospital. We've talked about a hospital infusion center. I see an infusion center, which is more of a standalone entity. I see a physician's office, and then I see home. What is it like for the patient when they're at home and someone knocks on their door and they get infused? Who is it? Is it a doctor? Is it a nurse? Is there a stretcher that they come? What happens? What is it like?
So that's a great call out, Rich. So with the home infusion service process, the patient can get their infusions in the comfort of their own home. So it's convenient because the nurse with the medication is pre-mixed, and it travels with the nurse to the home at a designated appointment time that's usually during the day, and there are also evening and weekend appointments as well, which has a lot of benefits to the patient and to the employer, as we'll mention later on in today's presentation. And so a lot of patients really like it because of that convenience factor and the comfort factor of being in their own home. There's a sense of privacy, and it's just a win-win situation all around.
What happens if something goes wrong? Is the nurse prepared? Do they have the appropriate medical equipment to take care of an urgent situation?
That's another great question that's very popular. And so there are policies and procedures in place with every single site of care, whether they be the home infusion nurse, at the hospital, at a standalone infusion center, or at the doctor's office. And so they often speak with the prescribing provider first to discuss any pre-medications or medications that need to be administered to the patients to reduce the chance of those infusion-related reactions. And there are things within our policy that we've implemented, such as if the patient is new to the medication, they can get that first infusion within the hospital setting. And so that can alleviate any concerns about those types of emergent situations.
So if something unfortunate were to happen and an urgent situation arose, the provider, the nurse is fully prepared to deal with it. That's outstanding. So Dr. Lam, as we think about the value of the program, what is it like from a patient's perspective? What do they see as valuable?
Yeah, there's definitely a lot of advantages for the patient. So listed out on here are 4 different pieces that we've identified. There's the comfort piece. So as Dr. Dong mentioned before, these patients can get the infusion at the comfort of their own home. This is a key piece for a lot of patients who don't like to go to the hospital. So a lot of patients tend to like this increased comfort aspect. There's also the convenience factor. As I mentioned before, most of the time the patient will have to drive to the infusion center and make an appointment, find parking, so it's a very cumbersome process. But what you have with the site of care program is they can sometimes be done after working hours or over the weekends, so they don't have to take time off, and it's a lot more convenient for these patients. There's also an increased safety. So some patients can be immunocompromised, meaning their immune system's not just working very well, and so there's a greater risk with getting these infusions at a hospital setting. So if you're able to either get it at home or at a less risky site, such as a ambulatory type infusion suite, that might be more advantageous for these patients. There's also a better value proposition. So at a lower cost is what these patients are going to get the drugs at, because we had a negotiated rate, and so it offers a better value due to a better site.
Comfort, convenience, safe, better value. Dr. Dong, would you be comfortable sharing a specific example of a patient's experience?
Yeah, so we have a great example of a great patient experience with the site of care optimization program. And we had one patient that had to travel 2 hours in a rural setting to the hospital to get the medication infused. They would stay there for 2 to 4 hours and then was nauseated and felt ill every single time after the infusion, and would have to endure the 2-hour trip back home. And so we were able to connect with the patient, and we connected the patient with a home infusion service. And so in contrast to that experience that the patient had, the nurse with the medication went out to the patient's home. They stayed there for the duration of the infusion, and the patient was able to crawl into bed right after. So that patient is still on the medication and still receiving the benefits of the site of care optimization program.
So for that particular experience, they're in the comfort of their own home, very convenient, reduced travel, very safe, and a better value for them overall. I'm sure you have many examples of the successes of the program from the patient perspective. Let's switch now to the employer perspective. We do know that these medicines are very expensive, and they're a pressing cost issue for not only patients but also employers. Dr. Lam, the value of a site of care or a medical drug management program for employers would be?
Yeah, so we've certainly talked a lot about what the value is for the patient, but there still is a lot of value for employers as well. The first being the lower cost of care. So when you're getting better drugs at a better value going to the patients, you're going to lower the overall total cost of care to the employer. There's also that improved productivity piece. So as we mentioned before, oftentimes the patient will have to take time off of work or take sick or vacation days even to go get their infusions. When you have a site of care in place, they can do this after hours or even on the weekend. So for the employer, they're going to have their employee at work at the designated time. So that's great for them. And that last piece is the adherence. When you have less hurdles for these patients, it's more likely that they're going to be adherent to their medications, meaning they're going to go get their infusions on time. So with better adherence, you also get better health outcomes. I've talked to Dr. Dong before about some of these cases, how it improves values for the patients and also, how it improves value for the employers. Dr. Dong, would you mind sharing with the audience some of these stories that you've told me about how this has impacted employers?
Yeah, so before I get to the story, I do want to level set and provide a little bit of background into the two different types of medications we do see in site of care programs. So one type of medication a lot of patients are on, and they cover a lot of disease states, again, such as rheumatoid arthritis, Crohn's disease, ulcerative colitis. So a lot of patients are on these medications, and there are some savings with every single infusion. And the second group of patients are on they have rare disease states. So these are those orphan drugs that really treat rare conditions. And so those are really expensive medications. And so we do have one of many patients that have one of these rare conditions. We were able to connect to the patients, talk with the doctor through a case management program, and really connected the dots with the home infusion provider. So we moved, of course, with the blessing of the patient and the provider, moved the patient from an expensive hospital outpatient site of care to an home infusion service. And so with that patient gets this particular medication once every 2 weeks, and there's a cost savings achieved of about $50,000 every infusion. And again, these types of drugs, they don't treat the disease state, but they help manage the condition. So $50,000 saved once every 2 weeks, it's close to $1 million a year.
Significant amount of savings. Thank you both. Well, we've outlined a pretty significant challenge. We've talked about drugs that are in the pipeline being on the pharmacy benefit and on the medical benefit, but the medical benefits medicines are predominant right now, and our forecast is to be predominant in the future. We talked about how complex they are to manage and to administer as well. We've talked about a fragmented system. We've talked about brown bagging, white bagging. We've talked about an integrated solution and provided very good examples of how it benefits the patient, the value from a provider's perspective, and it overall simplifies the care experience for the healthcare ecosystem here. As traditional, as we always do, we want to spend a little bit of time at the end here talking about key questions to ask when evaluating a medical drug benefit program or a site of care type program. So I'll turn it over to Dr. Lam to talk about critical ways for evaluating these types of programs.
Yeah, so the three key questions that you want to ask your PBM is first, if they can provide examples on how medical drugs are evaluated to be included within a site of care program. This evaluation piece is going to vary from PBM to PBM, so it's essential that the PBMs really focus on the clinical evidence of a drug, the medical efficacy, as well as the cost savings to really ensure that the program is successful. The next question that we have on here is, can they provide some examples of how facilities are included in the medical drug management network? Because we want to ensure that this is a holistic approach that is taken so that these facility relationships that are delivered and developed are integrated. And when you have an integrated experience, the patient tends to like that a lot more. And the last question is if they can describe how a patient experiences the medical drug management program. Certain programs will engage the patient a lot more, and we've seen that programs that really have the highest level of patient engagement always delivers the best outcomes for patients. So those are really the key things that you should keep in the back of your mind and pose to your PBM if they're thinking about doing a site of care program.
Absolutely critical to get the right medicines into the program. Absolutely critical to be inclusive, not exclusive, in terms of who's in the network. And finally, you can't forget the patient. Always have to keep the patient at the forefront. Well, thank you both, doctors. It's been a good discussion. I appreciate the thought that went into this presentation. Right now, we'll turn it back over to Dana and for our close.
So at this time, we're going to open the floor for questions. Remember, you can submit your questions by typing them into the dialog box, and we'll send them over to the presenters. We see people busily typing, so speakers, feel free to take a drink of water before you begin answering. If we run out of time or have any questions that need additional research, we'll follow up on those after the webinar. Okay, Rich, I'll pass it back to you now. And the first question actually relates to the cost slide that we went over. So if you want to turn over to that slide. If the total costs differ by sites of care, so we'll go back and then we'll address this question so everyone understands what we're talking about. So back about one more, there you go.
All right, so the first question is, what is the percentage of drug costs compared to? 128 versus what baseline? 267% versus what? Reference to price comparison slide, it says.
So as we look at this slide here, we're just looking at the total drug cost, not necessarily just one drug. So when we look at the 267%, that's actually the ASP cost of the drug versus at baseline, 128% would be the comparator ASP price percent.
So for my own knowledge, what does ASP stand for?
Average sales price.
Thank you.
All right, question number 2. If a drug qualifies for a site of care program, can the patient select any site of care option? Are there restrictions on home or infusion sites for the patient? Dr. Dong.
They can select any site of care option within the network. So the only restrictions are within the network of that particular site of care program with that health plan or PBM. And so that gives them a wide variety of choices when the site of care program has a broad infusion network, as we mentioned before. Again, those sites are home infusion, standalone infusion suites, hospitals, and doctor's offices.
Closely related to that is another follow-on question. Let's say that a patient elects one site of care at the beginning of their therapy. Can they change throughout, or are they locked in to what they choose?
So they can change throughout. Generally, they get comfortable with the setting, and the provider gets comfortable with that service provider as well. So they tend to not change when possible because they do need these infusions on a regular basis. But they do have that option if they so choose.
A couple more questions here. Really good questions today. We appreciate that. This is a building question, it looks like. Is developing an infusion network or facility relationship something that is always updated? Is it an evolving process? Is it necessary to stay competitive in the marketplace, or do you build it once and you're done?
So it is an ongoing process. Things can change. The market has changed in the past decade, in the past 5 years, even this year. With the election, we foresee some change in the future. And so because of that, the contractual obligations, the network service providers, a good health plan and a good PBM, they constantly evaluate those relationships for their patients and their employers that they serve.
Thank you, Dr. Dong. And last question for today is, what has been the experience with patients in a site of care program when the patient lives in a rural area? Do they have access to contracted sites or home infusion? How does it work when I live a long way away from a doctor or a facility?
So within Omega Rx, we do service and provide pharmacy benefit services for the region's health plans within Washington, Oregon, Idaho, and Utah. And a lot of our population does live in those rural settings. And so they are serviced by national home infusion service providers. And a lot of the patients really enjoy that service because of the long distances that they previously had to travel to get their infusions. And now they can get the infusions in the convenience of their own home.
And that sounds like that's part of the core criteria for an integrated program, a broad infusion network that can get to patients wherever they are, whether it's urban, suburban, or very rural. And that was our last question. So Dana, back to you.
Great. Thank you, everyone. Please join our next webinar on December 15th from noon to 1. You can always find the latest information for the RxTalks webinar series at omedarx.com/RxTalks. We will send a follow-up message to everyone on the call that will include a link to today's presentation and recording. Feel free to complete the survey when you disconnect from the call to let us know what you think about this session. Thank you for attending and have a great day.